My name is Chloe Fowler, and I did my proposed study on inhibiting CREB phosphorylation during memory reconsolidation, which would be a mechanism-based approach to PTSD treatment. PTSD is defined by the American Psychological Association as a psychiatric disorder that can develop when an individual experiences a traumatic event where there either is an actual threat to their life and well-being, or they perceive that there is one. The DSM-5 divides symptoms into four main clusters, which are avoidance, intrusive memories, hyperarousal, and negative alterations in mood and cognition. Current treatment plans for these individuals are mainly symptom-based, so this means that the symptoms are treated and not the root cause of PTSD. This can involve being prescribed anti-anxiety medications, antidepressants, having a long list of therapeutic approaches on their treatment plans. There is no unified pharmacological solution. An example of this would be if you have clinical depression, you're prescribed an antidepressant. A mechanism-based treatment approach would improve treatment plans and promote adherence to them, because one of the main challenges with PTSD treatment is that it can be overwhelming for the patients and cause treatment fatigue, eventually leading them to abandon their treatment plans altogether. There's also inconsistent symptom relief across patients, which you see with every disorder and every treatment plan, as it is characterized to the individual. However, when you have a unified pharmacological solution, it is generally more consistent. So a mechanism-based solution would address the root of the PTSD symptoms, which is persistent reconsolidation of the traumatic memories, and it would also reduce the emotional intensity associated with traumatic memories without actually erasing that memory. Before I get into the actual study, I just wanted to give you some background information. So memory reconsolidation is defined as a dynamic process where stabilized memories become malleable during recall. This enables the memory to update with the new emotional associations that are caused by how the recall makes you react. During this time period, they're vulnerable to destabilization. So I've included a diagram on the side here, and it will show you that when the memory is reactivated during recall, it is transformed into an active state where it's then vulnerable to reconsolidation or restabilization and then put back into its inactive state in long-term memory. So when this happens, the link to PTSD is that you recall the traumatic memory, and while it's in the active state, the negative emotions and the fearfulness that you feel are then encoded into that memory. So then when it's in the inactive state, it causes you more of that negative emotionally salient experience. So I also wanted to talk about the cyclic adenosine monophosphate protein kinase A cyclic adenosine monophosphate response element pathway. This is brought up in Eric Kandel's 2012 article on Alzheimer's research. In this process, it's very important in long-term memory formation. I included a diagram because it is a little bit confusing, but basically ATP binds to CAMP, which then activates the PKA, which phosphorylates or adds proteins to the CREB, which binds to the CRE, eventually enabling gene transcription of long-term memories on our RNA. So this is important for PTSD because the CREB phosphorylation strengthens the traumatic memories by encoding them into our long-term memory. By inhibiting this process, the emotional intensity of the recalled memory can be weakened without erasing this actual memory. The pharmacological intervention that I'm proposing involves the H89 molecule. This is a highly concentrated dihydrochloride that inhibits PKA by blocking the ATP from binding to PKA's catalytic subunit. This prevents PKA activation, stopping the phosphorylation of CREB and interrupting reconsolidation of the memory while it is in that active state. The potential benefits of this include decreased emotional salience of the traumatic memories and maintaining the memory's integrity, which means there's no risk of erasing it. H89 has been used in previous studies, mostly on rats, for Alzheimer's, Parkinson's, cancerous cell apoptosis, and cardiac arrhythmias. Let's get into the actual study. So the participants would be 100 adults between the ages of 18 and 65 who not only have a PTSD diagnosis as defined by the DSM-5, but are also currently exhibiting moderate to severe symptoms, which would be validated using the PCL-5. They also would need to be from diverse demographic backgrounds, ensuring the study is generalizable. In order to be included, they need to have a traumatic event meeting the DSM-5's PTSD criteria, and also no contraindications with the H89 molecule, meaning they wouldn't be at any risk for a severe reaction. The study would take place in a clinical research facility that has both psychological and medical monitoring capabilities, so that if there was a medical emergency during a session, they would have immediate assistance available. The study would be both double-blind and placebo-controlled, meaning there would be random assignment to the experimental group and the placebo group, and neither the participants nor the researchers would know. I think this would be best for this type of study because it would be clear whether or not the pharmacological intervention is effective due to the discrepancies in the PCL-5 score reductions of the participants. The intervention would involve weekly memory recall sessions for 6 weeks, followed by biweekly sessions for 12 weeks. At these sessions, they would recall the traumatic memory associated with their A1 criterion event, which is what their PTSD diagnosis stems from. Immediately after this recall session, they would be injected with the H89 molecule, which would interrupt memory reconsolidation, decreasing emotional salience of that memory. The follow-up sessions would be both 6 months and 1 year after the trials to ensure that a longitudinal approach is maintained so that we can make sure that the effects are sustainable across time. The outcomes would be measured through both self-reports and physiological measures. Self-reports would be through the PCL-5 being administered at the beginning and end of each session, and the physiological measures would involve their heart rate changes and their skin conductance. So the short-term goals of this study would be a significant reduction in the emotional reactivity to the traumatic memories that the participants are recalling. It would also be decreased PCL-5 scores in the experimental group as compared to the placebo group. The long-term goals would be a sustained reduction in the PTSD symptoms at 6 months and 1 year post-intervention, which is what we would be measuring for at those follow-up sessions. I would also like for the physiological markers to show reduced reactivity during recall, meaning their heart rate isn't increasing as much, they aren't sweating, and they just overall look less upset. So my hypothesis is that inhibiting CREB phosphorylation will disrupt reconsolidation and weaken the traumatic memory intensity without erasing the memory. To analyze my data, I would use a mixed ANOVA to compare changes in PCL-5 scores across time points, and a longitudinal analysis to assess the sustained improvements at the follow-up appointments. The key metrics involve changes in the PTSD symptom clusters and also the physiological response declines. The significance of this would be the clear evidence of the emotional salience reduction without erasing the memory. The study would have multiple implications, including moving PTSD treatments beyond the symptom-based approaches towards a mechanism-based intervention. There would also be a clinical impact where the reduced treatment burden for patients would result in fewer therapeutic sessions needed and increasing patient adherence, which would improve long-term outcomes. It also brings the potential to treat other maladaptive memory conditions like phobias and anxiety disorders, because if the H89 molecule is effective in decreasing the emotional salience of traumatic memories, it could also be used with memories associated with the phobias or the anxiety disorders. So in summary, the study would be targeting the CAMP PKA CREB pathway, disrupting memory reconsolidation and reducing PTSD symptoms. H89 shows promise as a pharmacological tool to weaken these traumatic memories. And for future directions, I'd like to see larger scale trials and the development of an anti-PTSD medication. This would signify a paradigm shift in PTSD treatment, offering a more targeted, effective, and ethical solution. These are my references, and thank you for watching my presentation.